Thanks for joining us. Our session is about Unicancer digital projects to improve cancer patients' care. To begin, I would like to explain that for those joining us virtually, you can send your questions by clicking the Q&A on the right side of the screen. And to get to know the presenters more, you can view their profiles in the Congress app. In introduction, I would like to underline that the progress made in the field of real-world medical data and artificial intelligence, AI, play a huge role in oncology. Oncology professionals need to combine parameters of increasing complexity. Firstly, to define efficient treatment protocols, the emergence of new AI techniques is changing the landscape of cancer prevention, diagnosis, screening, and tumor characterization. Secondly, possibility to analyze and share big volumes of high-quality health data can accelerate research projects and shed light on the therapeutic advances made in recent years and their impact on patient management. I would like first to introduce our first speaker, Professor Mario Campan. Is it okay? So Mario Campan is Vice President of Unicancer and Chief Executive Officer of the Institut de Cancérologie de l'Ouest, one of the French Comprehensive Cancer Center of the Unicancer network. He is a university professor in oncology and member of several international professional oncology organizations. He is a highly cited researcher and author or co-author of more than 300 publications. And his main areas of scientific interest are translational cancer research, the determination of predictive and prognostic factors in oncology, and the development of new anti-tumor agents. And Mario Campan is with us virtually as a presentation about the world of oncology in 2030, a new revolution. Thank you, Mario.
It's a great pleasure of the name of Unicancer to present to you the strategic policy of Unicancer concerning the digital revolution dedicated to the care of patients in oncology. In the field of oncology, we will witness in a new revolution. Next slide, please. Next. We are challenged to be met at the epidemiological level, increased concern due especially to the environmental factors. In terms of practice, we have a new approach to be promoted in order to adapt treatment according to the characteristics of the patient and the disease. It's a personalized individual medicine. In terms of support method and how cheap graduated course, the life course, at the economic level, we have significant resources to be allocated. At the therapeutic level, a structural boom in the cancer drug market. At the social level, promote access to healthcare, meet the challenge of the prevention, and prepare the reform of funding methods. Next slide, please. This revolution will reinforce the model of comprehensive cancer center. In interaction with the ecosystem, the hospital of the future will be an hospital where the care reinforces the research and the research care. We'll adopting a policy of evolution, the practice, and economic efficiency. Next slide. The hospital of the future require an adopted organization, infrastructure, and policy And the key to meet this challenge is a specific organization navigation of the territory with a chance practice and organization, more personalized, interdisciplinary, multidisciplinary, comprehensive patient care, a new skill. In terms of infrastructure, you have a digital revolution, data and biological warehouse, and AI tools. And a specific organization policy named the traffic management. Next slide. In this context, Unicancer established a strategy plan. Unicancer grouped together the 18 French comprehensive cancer centers and an affiliate member. Your network treats approximately 10% French cancer patients. High quality, ambitious, and innovative solutions are needed to improve the outcome and quality of life. However, modernization and deployment of digital require long-term funding. Delay are observed between the innovation cycle and the time needed for validating projects. Next slide. The priority of Unicancer network. Internally, we create of the Unicancer department for health data and partnership to provide the scientific community with robust real-world medical and epidemiological data, sharing innovative approach with our network related to AI, digital application, health data, telemedicine, and Unicancer Innovation Award 2020. Next slide. A priority for Unicancer network. Externally, we hold the launch of major national AI and cancer plan. Unicancer mounted several proposals during major national political consultation to promote digital development and strengthen the dynamism and excellence of French cancer research. Contribution to the 2021 National Strategic Council for Health Industry about innovation in health, and integration AI and data science in multilateral projects. For example, the France Medicine Genomics. Next slide. Your flagship program, for example, NISME, is the largest European source of real-life oncology data, which thanks the collection of data for a lot of patients, and linked to more for 14 innovative research projects and a major international publication. Cancer is a powerful search designed to big data in oncology to help physicians and researchers to identify pathology and specific situations containing the hundreds and thousands of medical records for Unicancer. Next slide. DeepSource is a project linked by Unicancer President for Jean-Yves Blais, alongside the team of the 3 Unicancer Centers to study the impact of different sarcoma treatments in order to determine the most appropriate therapy. The OncoData Hub, resulting from the partnership and Roche, this project aimed at the setting up a national oncology drug observatory. It is the first French public-private structure expected to accelerate the production and exploitation of the real-life data. And UNIBAD is a project developed in collaboration with the Health Data Hub to centralize cross-reference and share data between Unicancer and the hospital structure using a common language with a complex security. Next slide. Thank you for your attention.
Listen to our second intervenant, Julien Guérin. Sorry, I take. So, second speaker, Julien Guérin. You are the head of the Health Data Factory at Institut Curie, the Paris Comprehensive Cancer Center from the Unicancer network. You are an IT architect with a master in bioinformatics, and you worked during a couple of years as a consultant for the government to support strategic systems development. And you are currently involved in many projects of health data warehouses and promote innovative service based on artificial intelligence. And you're one of the leaders of the Unicancer national projects, Consor and Unibase, and member of the OSIRIS consortium for data sharing in oncology. And you will present Unicancer projects about real-world data. Thanks.
Thank you, Sophie. So I'm very glad to be here at EHF Congress. I will share with you a couple of projects we have within the Unicancer network and how we are gathering available energies to unleash the power of real-world data in the context of oncology. First, I would like to share a couple of thoughts to put the context. We are all hearing about artificial intelligence everywhere. AI is coming and will revolutionize patient care in the near future, but to achieve this goal, there are still a couple of steps to cross. Before AI, we need to focus on data first, because data today are not AI ready. And the second thing is precision medicine has emerged as a very efficient way for describing tumors and deciding the best treatments. As we are describing tumors at a molecular level, cancer is not anymore a couple of diseases, but a multitude of rare diseases. And we can't consider doing studies in a single center because population of patients for a specific disease is very small. That's why we need to think collaborative. We need to better cartography available data at a national scale and over the globe. We need to share data. Second thing I would like to share is there were a positive convergence of trends the past decade, which has allowed us to create new innovative systems for handling health data. First, we faced to an exponential increase of health data, especially with the rise of NGS sequencing. In the meantime, new technologies arrived in the market for harnessing large-scale data sets. And we saw at the end that the important cost we paid for maintaining clinical databases become a waste because this tremendous amount of data we have, this cannot prevent from the data obsolescence. Okay, so now we can talk about real-world data, but what's really real-world data? Mainly, it's text, because our physicians will remain poets. We won't ask them, especially in France, to just structure data. They will write medical records anyway. And 80% of the relevant clinical information is written by our clinicians in medical records. That's why we need to use today algorithms to handle the text and doing some natural language processing for inferring clinical information within the text. And this is the project Consor. In this context, we started Consor in 2013, and the project today is gathering 10 deployed centers in 2021 across France area and within the Unicancer network. And Consor is a unique federated network of data warehouses which are connected together to enable search on a population of more than 2.5 million of patients. Here are the initial sorry, I was late on my slide. Here are the initial requirements claimed by our experts when we want to start on the Consor project. First was to identify patient cohorts and asking any questions to the system. Within a powerful querying system, a physician told me, yeah, we need to answer the question in less than 1 second. No matter what, if you have 1 million of patients or 5. So we need to have a system that can process large volume of data and can infer information and return relevant results. It's not Google just to index concepts. It's really how the system can understand oncology and give to a physician an answer with the relevant results. And data needs to be updated in real time. And the last point is that people wanted to work together at a national level, so the system should be federated, and we should be able to query within the federation of data warehouses. So to work, Cancer needs two things, data sources, but also dictionaries to have a medical knowledge. Obviously, we are aggregating every medical record we have. We're also aggregating some information about demographics, tumor characteristics, all the chemotherapy treatments, the DRG for activities, all the biobanks, the clinical trials inclusion, the list of the medical images available in each center, and also the lab results. And to understand all of these data sources, the system has a couple of terminologies like ICD-10, SNOMED 3.5, the French pathology nomenclature called ADICAP, the French medical classification for ACS called CCAM, and the VIDAL for the drug classification. And with that, Cancer is really able to treat all the documents that are produced in a center. So to give you an overview of the amount of data it represents in a center, like Institut Curie, it's today 550,000 patients. It's the whole population of Lyon, to give you an idea. And we are gathering more than 15 million of documents in the system. So it's like just interpreting in a couple of days 80 tons of paper. And we also have 10 million of medical images references and also other sources like lab results, genomic data, and patient journeys, more than 2 million. So at a national level, we have an overview. So this is 2.5 million of patients, over 55 million of documents that the centers are aggregating right now in the system. And when we are indexing all the concepts, it's over 600 million of medical concepts. So how it works? Simply, I don't want to do a technical talk, but simply the system is aggregating the data sources I've just mentioned sooner. And when we are indexing the sources with the dictionaries, it's not enough. If we are just doing that, we will have Google, just to give you a search bar when you can find index. No, now the system needs to, with the concept indexed, to infer data and rebuild the medical history of each patient. And this is a phase of inference. After the indexion of all the documents, the system will just try to interpret the history like a physician will do in a center. And at the end, this will reproduce a timeline with all the events and all the tumoral events that happened for a patient. So for doing that, we need a couple of NLP or machine learning algorithm, and especially because we need to have the context of the document, we need to see if a medical concept has been indexed in a negation form or an hypothesis form, or if it's a personal history and not the current disease of the patient, or if it's related to someone in the family. So this is all things that can make some noise when you want to treat the document. So with our system of algorithm, we are reducing the noise of what Cancer can just query in the system, and we are able really to have a very powerful algorithm for negation and hypothesis. So, sorry. So just to give you what's the query builder, this is the thing like that. On the top of that, you have a bar when you can just put some suggestion, and the system will give you the items available. So if you want to search here, like a female with diagnosis of breast cancer under the age of 35 and treated by tamoxifen and letrozole, you can put this query, and on the fly, the system will give you how many patients you can retrieve in the system. So it's really in a couple of clicks that you can do that. At the end, you will retrieve this kind of representation with a timeline. And on the timeline, you can see all the events of the system, of the patient, all the treatment he received, and also all the available material like samples or images you can find for the patient. You can also have information on the related pathologies and also on the specific dates during the patient care. And on the left, you have a column when you can see also in the other centers how many patients you can retrieve with the same criteria. And this is the power of Cancer, because you can, in a couple of clicks, identify patients in the France area, and you can just then ask other physicians in other centers for really building studies. To give you an idea of how it's used in Institut Curie, today, now, we are really reducing the time for building studies. Here are 3 projects we built a couple of months ago, and it's the same. For identifying patients, it takes less than half a day, and we have really good results with that. And then we need just a couple of days for preparing data, preparing CRFs, pre-filled, and then the study can start. So really, you can see here that with Cancer, we can easily reduce the time for starting a study. Saying that, it's fine. We think with Cancer, we find a gold mine, but it's not enough, because we have other things. When a patient has a disease, he moves, and it's not is not really treated in the center. He can move everywhere, and when he's not in the center, we are losing him, and we missed some information. That's why we started a new project based on Cancer, but to be linked with a national initiative called the Health Data Hub. And the idea came up when a clinician received several patients with non-small cell lung cancer with the same tumor characteristics, with the same EGFR mutation, and who took the same TKI treatment. But he couldn't explain why one of these patients who got his pilot diploma started again to fly a couple of months after the treatment, while the others had an extensive progression and finally died. So there are obviously some other aspects to consider, and especially on the field of co-medications. And if we want in France to have the list of all the medications a patient is taking, we don't have all the information at a center level. We need to go in the national database of reimbursement to see what is got in the pharmacy. So today, the Health Data Hub is opening data, and we can link all data with the data available at a national level in the Health Data Hub. And in this context, we create the project Unibase, and Unibase is now a reality, and we will, in the coming months, trying to link the Cancer network with the Health Data Hub to build a national database on oncology. And we will start with a couple of pilot projects, three projects. We will identify at the beginning of 2022. And this will allow us to send some data coming from Cancer and to link this data with other data sources available within the Health Data Hub. And we obviously hope we will try to answer the question the clinician asked about how we can, how the impacts of co-medications in this kind of lung cancer. So just a couple of takeaway messages. Today, cancer research has to be a collaborative research, especially in the field of real-world data. and data sharing is really required. We need to speak the same language in oncology if we want to move forward. The Unicancer network leverages this new technological era for building a unique and powerful federated search engine, Cancer, which improves significantly the way to dig into EHRs and accelerates cancer research. And Unicancer is now making important efforts to connect its data ecosystem at a national level, Unibase, and beyond. Thank you.
Thanks a lot, Julien. Our third speaker is Professor Anne Labrie. I would like to introduce her, and she's online. Maybe we can... Is she connected? Yes?
Hello.
Thanks a lot. Hello. So I introduce you, Professor Anne Labrie. Professor Anne Labrie is dedicating clinical teaching and research activities to pediatric, adolescents and young adults, radiation oncology at the Institut Claudius Regaud of Toulouse, one of the French comprehensive cancer centers of the Unicancer network. Our research field is anatomic, metabolic, and molecular imaging for the optimization of radiotherapy. She is the author of more than 80 articles and book chapters on pediatric radiation oncology and on advanced imaging for cancer treatment optimization. She coordinates several multi-center translational research prospective trials and studies funded by national grants, Spectroglio, Impala, and Epidemiologics European Study, winner of the 2020 Unicancer Innovation Awards, to develop a radiogenomic signature with a multidisciplinary deep learning approach to improve the outcome in this frequent pediatric brain tumor. And Anne, your presentation is dedicated to epidemiologics. Thanks a lot.
Thank you very much for this complete and nice introduction. And I'm very happy to talk about this important subject about pediatric brain tumors. So it's indeed the Epidemiologics project because I work on pediatric cancer, and the most frequent pediatric cancer is brain tumor. And among brain tumors, the second most frequent is ependymoma. And we treat children with surgery and radiotherapy. But unfortunately, half of the children or adolescents will experience a relapse. We treat here, just an example, it's mainly posterior fossa tumors. And we do radiotherapy here once the surgeon has resected the tumor. Rapidly, the workflow of radiotherapy to understand after the subject we have for Radiomix in this particular disease. The workflow for radiotherapy is doing always a CT scanner and using MRIs, which allow to better see the brain tumors, and then fuse the images, define where are the targets and what we want to avoid, and then treat the patient, and then do a lot of follow-up MRIs, and sometimes see late effects or see relapses. The problem of this 50% of relapses brings us to asking ourselves, what can we do to predict the risk of relapse or predict the site of relapse? And can we identify risk groups to have some children and adolescents undergoing more or less strong treatments identified by molecular biology or by imaging data? And can we finally modify the radiotherapy dose and volumes? Because with the new techniques in radiotherapy, if we have better targets defined by, for example, imaging, molecular imaging, we can increase the dose without increasing late effects. So our first work was the PEPI study that I drove. It was in the last years. I gathered with my team a large data set of 200 patients treated in France between 2000 and 2013, and we realized a web database. And from that, we asked ourselves questions on the types of imaging. What would they bring, the different types of imaging? Could we escalate the dose? What were the clinical outcome of the children? If they relapsed, where did they relapse? Could we re-irradiate them, and what were they becoming? And it's quite a good approach. And we did a lot of work on that. And what we saw from these first studies from this large database is that we know that there is a high relapse rate. We know that there are molecular prognostic factors, and there were also very important publications from anatomopathology teams. And we had a large set of imaging and those data. And for the moment, we could only compare them one by one. And we felt it was really insufficient and that we needed the help of artificial intelligence to go for Radiomix plus genomics with the molecular pathology and do radiogenomics. I hope everything is fine with the slides. You can see them on the way. So the issues of image analysis are very important because these children undergo a lot of MRI examination. There are many images in each MRI examination, and they are required in many different centers. And moreover, there are many limits of the visual analysis by the human eye, and there are a lot of richness in images that we can't depict ourselves. And first, there are a lot of traps, for example, in which we fall usually, because here is just one example. It's the Adelson's checkboard, and you can see that there is a shade on this checkboard, and that you would say that A is much darker than B. But in fact, in real life, when you really take off this shade, they have the same color. It's hard to believe, and I encourage you to look at Adelson's checkboard videos on YouTube. You can really see it. For example, here, this band is completely the same color from here to here, and you don't see it the same because it's not in the same environment. And our brain compensates for variation in brightness for more stable results. So in everyday life, life is much easier this way. But when you go to analyzing data, it can be very misleading because it's a phenomenon of color consistency. And the other thing also with medical images and with tumor is that they are not regular, and they are very irregular in their shape and in their texture. And it's very difficult to characterize them just with the human eye or with human data. And we need more informatics, more statistics, and deeper analysis. And that's where we go for Radiomix. It's the extraction of a large number of imaging features that will give us the tumoral pattern and characteristics that fail to be appreciated by the naked eye. And first, we'll do a lot of image analysis. The shape, the size, we do histograms, we do filters, we do the textual features. And as you saw, we have T1, T2, diffusion, perfusion MRI, a lot of possibilities. So we can see a lot of tumoral characteristics, and we have now these types of analysis. And then we have to do visual and computational analysis. And then we need the help of artificial intelligence for many statistical modeling. When we talk about artificial intelligence, it's just very high biostatistics guided by very sophisticated image analysis or genomic analysis. And then we correlate them, of course, with the clinical data. Did the child relapse? At what time did he relapse? Where did he relapse, of course? And the molecular data. So that's the whole concept of Radiomix and artificial intelligence for analysis, the analysis of big data, of a lot of images. So if we go to this problem of high relapse, molecular prognostic factor, large set of imaging, and the use of artificial intelligence, we obtained help by the Unicancer, and we obtained this innovation prize. And then we obtained a large grant of the National Institute of Cancer for 693,000 euros to drive this study which will be Epidemiologics, will create a network to share data, and we will use all the MRI and RT data of children and adolescents before and after treatment, harmonize the images, and segment them, analyze them to have features, to have characteristics of relapse, of response to treatment, and do a large set of statistical analysis using images, dose, clinical data. And also we will link them with biology and also do deep learning, do artificial intelligence with biology. So we want to obtain biomarkers, to obtain finally a molecular and global signature, and go for different types of groups of children that could have more tailored treatments regarding the dose of radiotherapy, the volumes of radiotherapy, or the use of other treatments, additionally to surgery and radiotherapy. But there are requisites to do correctly Radiomix, and what is very important is to have a lot of patients. Then it's to harmonize the images, just like Julien said. It's very important in order to compare images. And when you do this, you find these characteristics that tell you, for example, in such and such type of imaging, you are really predictive of the site of relapse. It can help you modify treatment. First, what you need to do is to validate, because there is a lot of bias if you just do a few, not enough patients, and you just use your type of data. So you have to validate on an external cohort. And for example, in our programs, that's what we do. So first, our French data contains 382 patients, because there is the PEPI database that are elaborated, and then all the children included in the current prospective European clinical trial driven by a French cancer center, which is Léon Bérard. Partner for harmonization, our partner for harmonization is renowned for Radiomix harmonization. And then we will validate on the UK cohort of this trial on 200 patients. Just to show you, it's a huge work, and it takes a lot of organization to collect data, to harmonize the images, to do the biomolecular analysis, and then the statistics that take a lot of time. And of course, to have all the regulatory acceptance and create an efficient database and collaborate. Also, the big thing is to collaborate with experts in their field. So the one who include patients, the one who treat patients in our cancer centers, and the experts in anatomopathology and biomolecular, the experts in imaging harmonization, and the external validation cohort experts. So the big thing is to gather the images, and it's really not so easy. Also, we now have the DICOM format that allows to exchange between hospitals. The good thing with the Unicancer centers is that most of them are linked with the ACTM system, so it's really easy to send from one PACS to the other. There are also new systems that you can go direct in the PACS of all the participating center of a project and go get the specific images of each patient without asking human interaction. And then you have to have a useful imaging repository for imaging data, for radiotherapy data. So there are a lot of initiatives, just like was explained in the precedent talk, to have a fiable and usable, reliable imaging repository system. So it's work in progress. But image retrieving still is a big struggle from the PACS, using, if possible, these networks between the centers, or the good old CDs by mail, but if possible, we would like not to use that anymore. The big thing, of course, is to have tight, clean images, and to check them. Once they are gathered, we need to check them, clean them, prepare them, select them, contour the volumes, because all this analysis, you have to do them on specific volumes. You just can't say, I take all the brain, or I take all the lung, or you have to control the regions you want to work in, and then do all these works that I detailed before: preprocessing, segmentation, extractions of the features, analysis. So it's a lot of work. And then you have to harmonize in a large scale the Radiomix data. So of course it's going to be, for example, in my study, more than 15 centers collaborating, and it's always the same with if you want to do very nice and useful works. So you have to harmonize the images because they are very, the Radiomix features are very sensitive to the difference in scanner models, scanner of CTs or MRI or PET, to the acquisition protocols, to the ways you reconstruct them. But now there are very excellent methods to harmonize and using also artificial intelligence. And then, of course, you have also to validate this harmonization on a large scale center as a cohort. So I will end up with these take-home messages. Radiomix, genomics, radiogenomics using artificial intelligence are absolutely essential to progress in cancer research. We need to have easier access and easier creation of imaging repositories for clinical trials, from clinical trials or for clinical data anyway. We need a robust harmonization of multi-center data. So in the end, it's a multidisciplinary action that's really supported by our institutions, like, for example, the Unicancer initiatives, to gather all the efforts of the physicians, the researchers, the imaging specialists, the biologists, anatomopathologists, and of course, the biostatisticians. And I thank you very much for your attention.
Thanks a lot. Thanks a lot for three speakers, Mario, Anne, and Julien, for your clear and complete presentations. I would like to conclude. We have seen that improving our knowledge of tumors biology and behavior is key to improve patients' outcomes and quality of life. We have seen in this session the major role of data sciences and AI, and innovative flagship programs in this field. At the international level, there is a need to push boundaries and make efficient use of technological and data processing tools, join efforts by capitalizing on innovation and exploit their full potential, and establish cross-border health data spaces for research. Thanks a lot. It's now time for questions. You have a micro. Are there questions in the room? And virtually, I check. I think there are no questions virtually, and for the moment, and in the room. Thanks.
Marc Potter from Fondation Santé Service Hospital et Home in Paris. I would like to ask you, do you have initiatives or something in mind to connect your database with the data that are at home? I don't know, primary care or hospital at home data, which I think could become something to add to what you are currently designing.
You're right. Nowadays, the pathway of the patients are very complex, and the links between home and hospital and expert centers like comprehensive cancer centers are very important. And we have some programs not presented here, but which are dedicated to how we can improve the coordination between home and hospital, and with a specific financement by the government, Article 51. And the objective is to evaluate the real-life data for the patients. It's between care and research. If you are interested in our programs, we can discuss, because we have a team which is dedicated to data partnerships, and I think it's interested to discuss. Thanks a lot. Is there another question? Second question.
Thanks for the presentation. Olivier Duncan, Trinetics France. That was very interesting to hear about data sharing and the importance of homogeneity in the data. Since Unicancer is a really patient-centric organization, I was wondering, how do you involve or engage patients in this digital revolution at Unicancer? Do you do something specific?
Yes, I can begin, and Mario, if you want, you can complete. So it's at the beginning of each program, we are including patient associations to the design of our studies, and they are associated along the different programs. We can take the example of MyPeps, which has been presented and advocated by Mario Campod, and the associations of patients in this program, for example, are included in the in the board, so as to follow the study and to give some remarks permanently. For us, it's natural to include patients and their representatives along all the studies. Another question.
Thank you. I'm interested in the statement that artificial intelligence analyzing imagery is better than the human eye. I have heard from other innovative companies in the USA who are using iPhones with AI and imagery to identify the potential skin cancers, and they have come across massive objections from incumbent oncologists and dermatologists who still feel that the eye is better and the experience and judgment is better than imagery and AI. I just wondered whether a similar reaction is expected or has occurred in the proposition which we were presented with.
Maybe Anne, if you have heard the question? Yes.
Yes, thank you for this question. Yeah, it's completely true. I mean, it's not, the idea is not to replace the human eye. Do you hear me correctly?
Yes.
Yeah, okay. The idea is not to replace the human eye, because we also have examples of artificial intelligence not even being able to differentiate a cat and a dog. So it's not really that. It's just going a step further, having additional informations. But it doesn't replace the fact that we keep being saying if the tumor relapses analyzed by the human eye, but then trying to find predictive factors, trying to find help when we cannot differentiate if the tumor sometimes is relapsing or is a mix with late effects. This can help, but it's really not one or the other. It's one plus the other on a large scale, but on an individual scale, the human intervention keeps being the best one. But I can tell you that radiologists are very pushing also for this artificial intelligence approach, complementary to the visual analysis.
Thanks a lot. There is a question, how can we get in contact with Professor Labrie? Could you please share your contact? So if you agree, we can send your email, because I think your presentation has interested a lot of people virtually too.
I'm on LinkedIn also.
Ah, you're on LinkedIn, okay. Thanks a lot. Thank you for the very interesting questions, and thanks for the speakers. Thanks a lot for our presentations, and I think if there's no other question, we can conclude our session. Thanks for your attention.